Good morning, everyone. Welcome to our webinar today about smart homes for health monitoring with nursing insights. We have Shelly, Fritz here today. Katie, unfortunately, is sick, it sounds like, so we're grateful still to have Shelly today. Dr. Shelly Fritz is a nurse scientist who has worked focused on application of smart home technologies in naturalistic healthcare delivery environments. She works with a multidisciplinary team of engineers, computer scientists, and neuropsychologists, developing clinically relevant health assistive tools to improve outcomes and lower costs of care for older adults with multiple chronic conditions. Her career has spanned 3 decades, with nearly 20 years working on the front line in public health, emergency nursing, and hospital administration. She was a National Science Foundation Integrative Graduate Education Research and Training Fellow and publicly elected hospital commissioner. She's been a repeated invited National Institutes of Health speaker on the role of sensor-based data in evidence-based practice, smart homes for aging in place, technologies for value-based care, and human-computer interactions in health delivery. She also advises multiple health technology startups. And I know that we've really enjoyed working with her here in the CASAS group at WSU, doing smart home technology research and getting her insights from a nursing perspective. Her goal is to develop an ambient real-time home health monitoring system that is an FDA-approved medical device, which could be prescribed for home use and paid by Medicare. Dr. Fritz would like to see more nurses at technology design tables and is building a lab to prepare future nurse innovators with skill sets needed by the technology industry. So with that, we're really grateful to have her here today to share her insights, and especially for those of us that come from a computer science perspective or outside of the nursing realm, it's really been valuable to me to have her insight and her experience here, and we're grateful to hear what she has to say. Also want to mention the Q&A is open, so if you guys have any questions, feel free to post them there. We'll probably answer most of the questions toward the end, but we'll also make it a little bit interactive, so you're also welcome to raise your hand with the button down at the bottom of the screen as well to ask any questions you have. And with that, Shelly, I'll let you go ahead.
Thanks, Brian. So I'm happy to be here today, and I wish I could see all of your happy faces this morning, but we're in a webinar style. So what I'll start out saying is, if you have a question that comes to mind while I'm talking, just go ahead and raise your hand, and Brian can interrupt me and I can attempt to answer it. But if you feel like you want to wait till the end, that's totally fine too. I feel like I grew up in the technology part of my career in the CASAS lab under the guidance of Dr. Cook and Dr. Schmitter-Edgecombe. So it's a pleasure to come back and talk with you all today from a nursing perspective. And so as you may not have as much of an opportunity to interact with nurses who have been on the front line for a lot of years, I encourage you to take this opportunity to ask me any question that you think is relevant to your future work or your current work. So with that, I will share my screen and we'll get started with the lecture. I'm going to leave time at the end for Q&A because I was telling Brian earlier, one of the things that I've learned in talking in particular with engineers and computer scientists is that just the straight up lecture style doesn't maybe get us as far towards connecting or crossing the chasm between our two disciplines as just Q&A and conversation. So again, feel free to ask questions. So thank you for the invitation. And again, Katie unfortunately cannot be here this morning, but she's here in spirit, and you will find some of her great intellect and knowledge in the slides that I present. I do want to also add that last year in 2021, I was chosen to become a Betty Irene Moore Fellow for nurse leaders and innovators. And it is a fellowship funded by the Moore Foundation. Gordon Moore started Intel. So that affords the opportunity to have some funding to also move the state of the science forward with smart home technology and home health monitoring. So today I'm going to talk about the current state of smart home studies that I'm involved with, that several of them, Dr. Cook and Dr. Schmitter-Edgecombe, are involved with as well. We'll talk about some of the study aims and findings, and that will just give you a little bit of an idea of what we're doing at WSU and sort of what's the state of the science out there. And then we'll talk about sensor information and how it can be utilized or can impact clinical practice, and this specifically from a nursing perspective. And then what do patients want? We'll talk a little bit about that, and then some future work that is funded but not started yet, which will give us an idea of what at least the National Institutes of Health and foundations like the Gordon Moore Foundation are interested in, which gives us an idea of appropriate directions for the future of this work. So I want to start by mentioning the funding mechanisms that you see here on the screen, and also just being grateful for the learning opportunities that I've had from Dr. Schmitter-Edgecombe and Dr. Cook. And this is Katie Wuestney. She's a PhD candidate, the one who's not here today, unfortunately, but she is working with Dr. Cook and myself and a nurse gerontologist on a dissertation that focuses on the smart home data. And I'll tell you a little bit more about that in a few more slides. So I want to situate my work in this sort of model that you see here, which is really circular. I started out in practice, actually, I hate to date myself, but in the late 1980s and in nursing school in the late 80s and early 90s. And then after 20 years, I came back to do my master's and my PhD, because I just found myself constantly at the bedside wondering, like, why do we do it this way? And why aren't we using this? And how can we harness technology to improve patient outcomes or improve the nursing process in whatever piece that I was working on at the time? And I always had a bit of an interest in technology because my husband is a software engineer. And on the Rogers diffusion of innovation theory, we have the early adopters. He's very early adopter to innovators. So I've had this opportunity, at least within my own home, to try to figure out how to use stuff in my own home, which led me to think about how that could apply in healthcare. So that led me back to research, and research is the area where we look at creating evidence and sometimes new forms of evidence, which I think sensor-based data can give us. And then we have to figure out how to use that in practice. So that's sort of the area where I situate this work. So in general today, I'm going to talk about smart homes and the data that they produce and how that can apply to health monitoring. And so this talk is situated in this idea that we deploy sensors into people's homes. We locate those sensors within the home based on the floor plan and the utilization of space within the home. And we choose sensor types based on what we want to be able to observe through the sensor data of human behavior and motion patterns in the home. So just to have you think a little bit about the idea of data and how we normally use data as nurses and as physicians or nurse practitioners or PAs, and then this sort of new idea of data and how we can integrate it for healthcare. So what you see on the left here is not a really great shot, but it is of a traditional electronic health record. And in this record, we are used to accessing things like lab values and x-rays or pictures that have been taken of the human body via an endoscopy or something like that. We have medications in there that people are taking at different times, their health history, their diagnoses, and things like vital signs. And when it comes to vital signs and maybe lab values, we can also look at trends. And that is sort of the data that we are used to looking at. The electronic health record helps compile all of that really well, and we can look across systems. And that sort of came out of the HITECH Act. You guys might be familiar with that, but electronic health records were a part of that mandate. That was to be fulfilled by 2020. And so most hospital systems, I would say all hospital systems, and even all clinics and most assisted livings and nursing homes are using the electronic health record. You might know the HITECH Act better from the HIPAA standpoint. So every time you go into a doctor's office, you have to say, yeah, I know you're going to keep my information confidential. That's how most people know that HITECH Act. But what we are looking at now in this research is how do we integrate, for example, wearable data and data from sensors that are placed in the home into this kind of record. So if you think about the electronic health record as this traditional information that we collect a slice of data at a period of time when we're in contact with the patient. So that could be a doctor's office visit, or it could be the emergency room visit or a hospitalization, but it's a slice of data and a slice of time. And that's how we're traditionally looking at patients. But what this other type of data offers us is the ability to continuously monitor someone and collect data in between the care points. So it's a really non-traditional way of thinking about how we know what's going on with a patient. But one of the reasons why Katie and I are really interested in this work is because there's quite a bit of literature that says that the data points that we collect on people when they are not in the doctor's office, or they're not in the ER, or they're not in the hospital, are actually more accurate. So for example, a blood pressure taken at home is a more accurate reading and a more valid reading than one that's taken in the doctor's office. So this particular slide talks about one of the studies that we're doing, and we call it the Clinician-in-the-Loop. And I'm showing this to you to sort of give you an idea of the process of what goes on and what we're doing with the data. So the hypothesis for this study is that ambient sensor data can be analyzed using machine learning techniques to provide insights on health status and to automate behavioral interventions. So we, as I showed in a couple slides ago, we put sensors in the home. These are motion, door, light, and temperature sensors typically. That data is collecting information, or those sensors are collecting information about the resident's activity in the home. And then we use activity learning or machine learning techniques to automatically label what those activities are. Well, where does the clinician come into that process? And by clinician, that could actually be psychology, or it could be nursing, or it could be sociology, or any other person that either has or will have a clinical practice someday. So what we do as nurses, as nurse clinicians, is we look at that raw sensor data and we help annotate for ground truth so that the computer is labeling activities that might be clinically relevant accurately. Then we also introduce interventions. And so, for example, Dr. Schmitter-Edgecombe's group does what we call a brain health intervention in our Clinician-in-the-Loop study. And they introduce healthy brain activities. And we look at whether or not we can see the start of those activities during this process and for how long patients keep going with those activities after they finish. So that can give us some ideas about adherence to treatment plans. That's really important in the healthcare world, because we can prescribe all we want to patients, but if they don't actually follow through, that'll have an impact on their outcome. And although they have choices, if we understand what their choices really are, we can help support in ways that make sense and are very personalized for patients. So I'm going to talk to you about 3 examples of work that we have done, and it will give you a better idea and better insight into this process that I just showed you in the previous slide. So with the Clinician-in-the-Loop study, this is going to be an example I'm going to talk to you about of a gentleman who fell in his kitchen. And we picked that up and we used it for training the machine learning algorithm to be able to better understand falls. So this is what the data looks like. Many of you might be familiar with this, but just in case there's people on this webinar that aren't familiar with the raw data that we look at or that is produced by the sensors, this is an example of that. So nurses analyze this type of data to provide ground truth for health events. And you'll notice that there's no labeled activities on here, and we don't look at the labeled activities for one reason is we want to look at the raw data and not have our ideas about what might be going on with the activities informed by an automated label. So we look at it in its rawest form to provide ground truth. So we rely on a telehealth visit that we do with the participants once a week, where we do basically a home health visit or telehealth nursing visit. We get their vital signs, we ask about what has changed in the previous week with their health, and we get to know them pretty well over a 1 to 2 year period of time. So oftentimes it's a very therapeutic conversation where we just target in on what we know the person is struggling with, be it congestive heart failure or whatever diagnosis that they have. We also do quarterly summaries of their daily routines. And so we know every 3 months, sort of what they are telling us is their daily routine from the time they wake up in the morning to the time they go to bed at night, and then what their nighttime pattern actually is. And we also have access to their medical records and use that for annotating ground truth. If we have questions when we're looking at the data and we're not sure exactly what we're seeing, we go back to the participant and we verify that, which I think helps improve the accuracy of the algorithms. We then provide engineers what we call health event start and stop times. And we tell them which activities that we think best represent whatever health event it is that we're seeing. So in this case, a fall in the kitchen, we might say that what we looked at was the normal trajectory of the participant, in that they normally are not in the kitchen at that time of day in that location for that period of time. So they're not following their normal trajectory. In one case, it was someone who fell in the kitchen in the middle of the night and was in front of the stove for 15 minutes, and nobody is in front of their stove for 15 minutes, typically in the middle of the night, certainly not this gentleman. And so looking at that trajectory pattern where we knew this gentleman gets up in the night, goes to the restroom, and then goes to the sink for a drink of water to soothe his thirst, which was associated with one of his diagnoses. So that's what we provide to the engineers. And then this slide tells you sort of what, as nurses, we think are some of the most informative measures that we can look at in the sensor data. So looking at bed to toilet transition, that's a pretty logical one, but we like to look at that from a number of disease perspectives. One of the most common ones that's published out there is urinary tract infections, and that's a pretty obvious one. But one of the ways that we look at bed to toilet transition is with regard to congestive heart failure and whether or not someone has taken, for example, a prescribed diuretic. It can inform about that. It can inform about older women with bladder urgency issues, and a lot of older women have bladder urgency issues and retention, and that can cause you to get up and move faster than you want to get to the restroom, and so can precipitate falls. And also bladder retention can affect the autonomic nervous system, and in some cases make people dizzy, which also can precipitate falls and land people in my emergency room. So one of the reasons for looking at this sensor data is this continuous monitoring in between the care points is to hopefully be able to look at things like bed to toilet transition and the walking speed associated with it to be able to identify early indicators that, for example, somebody might be having a bladder issue. Bed to toilet transition can also be looked at for GI problems. That's gastrointestinal problems. So around diarrhea, constipation, you can imagine that the use of the bathroom would inform information about that as well. We like to look at the percent time that people spend in each room and their activities, because we know that when people don't feel well, they don't move the same. They don't spend the same amount of time on activities, and oftentimes their routines will change. We like to look at sleep. and the overall unusualness of the day. That was a really cool algorithm that Dr. Cooks and her students helped create for some of us who wanted to see the total unusualness of the day. And that was an idea that came out of some really experienced nurses who are back in graduate school becoming family nurse practitioners, who could envision that this would be something that they would want from this data. So in this slide, I want to tell you a little bit about how we originally got to our method for providing ground truth for the engineers. We had two of us, Katie and myself, and then three very experienced nurses look at sensor data, become familiar with it, begin to envision, what could be done with it. And then we had them analyze 5 events on 3 different smart home participants. And we had simple and complex cases, health events for each of those 5 events. And you can see here that it varied. We started out with the first home. We had 2 simple events and 2 complex events, and we had full consensus on that. So we each independently analyzed this data, and we each independently chose a date and a start time and a stop time for these health events. And we had just 100% consensus on these health events. So then we took another home and we had 5 health events for that, 1 simple and 4 complex. And for that one, we actually just had 1 case where on one complex event, we were partially in agreement on the start and stop time, but we actually, the variation was just on the edges of the event. The core piece of the event, we were in full consensus on. And then on the 5th one, you can see that we were full consensus again. So we developed a process around that and ended up calling it the Fritz method. And that is what we use to provide ground truth for the engineers for the rest of the study now. And if you want to know more about that method, it's published out there. You can go read about it. So let's see, it's not letting me forward my slide. There we go. So I want to show you a little bit of an activity dashboard that we worked with engineers to develop. And also Dr. Maureen Schmitter-Edgecombe and her students helped with this. This is a dashboard that some of those nurse practitioner students who are experienced nurses back in graduate school helped us identify as things that we wanted to look at and how we might want to look at it. So a big challenge is how do you take all that sensor data and turn it into a visualization that nurses could use on the fly? Because if you think about nurses and docs as they go into a patient room, they don't have a whole lot of time to look at that record and look at that chart. So we're used to looking at those labs and those x-rays and those vital signs and et cetera, but we're not used to looking at what would this sensor data, what is it telling us? And so we came up with this idea for a visual dashboard. And these are just 3 of 8 things that we chose to look at, but overall activity level, bed to toilet transition, and relative walking speed. And this is just a portion of that dashboard. But if you look at the top row, activity level, you can see right here that there was a significant decrease in overall activity over about a 4-day period of time. So that's a pretty easy way to look at months of data here and say, there's 4 days that are not looking normal for this person. What's going on there regarding their health? So let's blow that up here. And you can see that this is about 4 days. The x-axis is the number of sensor activations, and the y is time. And the horizontal lines represent the number of standard deviations from norm. So you can see those 4 days right there. Well, that happens to be the 4 days that were the fall that I showed you earlier. So the fall happened right there at the beginning, and this person actually bruised their hip pretty good and couldn't walk very well for about 4 days afterwards. And then you can see they had a pretty sharp recovery time. So this is just to give you an example of how you could take this quantifiable sensor data and you can turn it into something that nurses and docs could understand. and be able to use in practice. So another thing that we did to look at translating this data to practice is we presented this to experienced nurses and asked them to look at data across 3 homes. And for this particular one, you can see the number of observed days, and then the nurses chose a certain number of actionable days. Actionable days would be days where we think that the patient or the participant is experiencing some kind of health anomaly, and it probably requires an intervention, or at least it should. They should see a nurse or a doctor and be evaluated, and probably we're going to do something about it, like give a medication or change a dose of a medication. And you can see that there was a variance in agreement when we took this huge amount of days and we said, take a look at this and tell us which days would be actionable. So the takeaway from this is twofold. One, that nurses and docs can actually envision what to do with this information. And the second takeaway is that we have a bit of work to do for how to present the information to them so that we could have consensus, because certainly in the treatment of any disease, there typically isn't a less than 50% consensus on the path forward. It's typically, over 90% of docs or nurses or prescribers would go a certain direction. So this is a second exemplar. This is an 86-year-old female that was newly diagnosed with lung cancer and started radiation treatment on week 10. So you can see here is week 1. This is when she was diagnosed with lung cancer, and then we move 14 weeks forward. So this particular participant actually also had a history of depression. And what we're showing here with this data is the point in which she was diagnosed, and then the point in which week 10 she started radiation treatment. And you can see that once she started radiation treatment, her activities and routines changed, and she broke a threshold. Using this type of machine learning technique, a virtual classifier, and also over here, and then the top level decision tree you can see. For this, we looked at sleep and enter home as the activities where we were particularly interested in whether or not this person's sleep and enter home activities changed. And those definitely, you can see that there was a threshold broken at week 11. Using all of these different techniques, we got the same finding on the same week. What's really interesting here, you can see that the W1 and W2, which is week 1 and week 2 are also green. Here is green because we broke threshold. Week 1 and 2 were actually abnormal as well. And clinically, looking at this data as a nurse, what I think is going on there is the history of depression is something that's relevant here. So she was diagnosed with cancer, and she actually stayed in the home more, had reduced activity, and probably showed some signs of processing that diagnosis in week 1 and week 2. So just another way to show you how we can visualize this data and what it tells us. So all of that's really good, but that's from the nursing perspective or from the healthcare worker's perspective. But what really matters to older adults? That's a question that is probably the most important question, because we can design all the really cool tech we want, but if our patients don't want to use it, then we sort of wasted our time. So here's what we found in multiple studies that I've done that ask the question about adoption. And I choose that word adoption specifically. So if you are in the engineering or computer science field, or you're a student in those fields, you may be introduced to like technology acceptance model as a model for designing technology. UTOUT, there's several of them. I use Rogers' diffusion of innovation theory for 2 reasons. One is because he uses the word adoption, and I prefer that over acceptance, because as clinicians, we have to be really careful about the over influence on patients, or what some people call white coat syndrome. And so we show up with a white coat in the room, and then, you know, the assumption is that you should do what we say. And that's not the way of getting better outcomes for patients. We have to really integrate their ideas and their thoughts and meet them where they are. And so this idea for me of adoption versus acceptance just has less implications for over influence in the conversation. So what do patients say that they want? These are the things that come out as themes in our qualitative studies, where we introduce the smart home technology and the sensor monitoring, and we ask them what they think. And privacy and trust always come up as really big ideas. This idea of invasion of privacy in the home. What I found is that older adults are very open to this technology for the most part. They recognize and have told me over and over, if they have to move to the next level of care, then they're going to lose privacy. And so they would rather maybe trade that for a little bit of perceived loss of privacy in the home versus the privacy that they will lose when they transition to the next level of care. Safety is important. So this idea of safety is both health and security related. And then there's a lot of talk about culture and language, and what is the impact of that, and is this only for, you know, people who meet some kind of normed culture, which we know doesn't exist, or is it only for people who speak English? That is something that has been brought up. Cost is perceived as a huge barrier. The older adults in our studies want Medicare to pay for this. So this is why I want to work on having this be a medical device that can be prescribed and therefore be paid for by Medicare. So let's talk a little bit about future work that's funded and that give us an idea of directions that at least funding mechanisms, which, you know, I always say there's wisdom in numbers. So if funding mechanisms think that this is a good idea, then probably you're on the right path. This is Katie's slide, and I'm going to present it for her. She sent me some text, and so I don't mess it up because she is a brilliant mind. I'm going to just read to you what she wants you to know about this slide. So she's looking at frailty and complexity for her dissertation study. And she says, many of the common pathways for making inferences about health from smart home data look like this, where we start with the raw time series of sensor messages, and then we label the raw sensor data according to the corresponding activities of daily living. Then we use the labeled data to train a model to be able to identify discrete occurrences of these particular activities in the data. Using this learned activity model, we then take the original sensor data and we label all of it according to learned activity labels, creating a new time series of activity labels rather than sensor messages. Then we use this activity sequence to make inferences about health status, either through a machine learning model or descriptive summaries. As you can see, this is a somewhat indirect route involving a few levels of data processing. One of the problems with this strategy is that it requires a decent amount of stability in our routines and how activities are performed, and it requires knowing ahead of time what types of activities are going to be most clinically relevant. And even then, most of us spend only about 50% of our day conducting routine activities of daily living, which means that about 50% of the data gets lumped into a general other category, which encourages greater and greater granularity of the data that we collect, which in turn translates to greater and greater intrusion on one's person and on one's person being monitored and their privacy being invaded. So she sets it up with we have to get more and more granular. And I do see that a lot of the technology is being designed in that fashion. We got to get more and more granular to really understand what's going on here and get biobehavioral markers so that we know what to do. And here's what Katie is hypothesizing instead, based on her nursing experience, which is her background is caring for persons with Alzheimer's or dementia in an inpatient setting, okay? So instead, she suggests that another pathway to inferring health from smart home data involves finding more global features of the raw sensor data that are directly related to health status. One hypothesis for such a global measure is complexity, measured via sequence entropy. The loss of complexity hypothesis, which has been demonstrated with other types of biosignals, states that when a person's frailty status increases, there is corresponding decrease in their physiological and behavioral complexity. This method would be a more direct health indicator for the data and also doesn't require the same kind of privacy intrusion and granularity of surveillance as other methods. In fact, this method does not even require any knowledge of where sensors in the home are placed or which activities are happening when. It just depends on the sequence of different symbols. So this is where Katie is going as sort of a new direction, which is different than what I have seen for other work with the smart home data. But I'm really interested to see what her findings are. She is in the middle of her dissertation work. She's a candidate, so we'll be interested within the next 10 months or so to see what her findings show, whether or not she can show that a decrease in complexity would actually be an indicator of frailty, which then could facilitate an intervention or action on the part of healthcare. So just really briefly, 3 other studies that are sort of in the works that are related to the Clinician-in-the-Loop study are an Alzheimer's and related dementia study. For this study, we do all of the same things, deploy the sensors into the home, we do the weekly nursing telehealth calls, we get the routine summaries, we get the medical record, and we use all of that to annotate for ground truth. But the aim of that study really is to improve the machine learning algorithms and have them be able to accurately discriminate between 2 people in the home, so where one of them is in cognitive decline. So for this, we're enrolling dyads and looking at being able to discriminate between who's who in the home. This will also really help with being able to eventually discriminate between people and pets. And that's a really important thing from a nursing perspective, because we know that pets are often really big in the lives of older adults as far as socialization and comfort. We also have a bioethics study that is ready to start now that we're past the peak of Omicron. All of these have been on hold because of COVID and or Omicron variants. The bioethics study looks at specifically if we can train an algorithm to monitor itself for bias and be able to use that to transparently talk with people from other cultural backgrounds or ethnicities or race about the sensors and the type of data that's being produced when we put it in their home. So this idea of privacy and the fact that this technology would do something that's actually going to add value to my life and not discriminate or perpetrate discrimination again and throughout the next generations is a really big question. And this is something that's been brought up by participants that have been part of my qualitative studies. And then we actually have a smart health system starting. We're calling it a smart health system because we're taking sensors, we're placing them in the homes of older adults who are experiencing low income. And we are embedding it in a people-based system. So we have the technology and people being deployed alongside each other. So we're deploying community health workers, which is a model of care that are trained health workers that don't necessarily have health backgrounds, but they are trusted members of a particular community that we train to do certain things related to health. And community health workers or community health aides have been used within the public health approach to care in the public health system for as long as I've been in it, since the early 80s. So we're deploying the technology and the community health worker alongside each other, and we're going to see if we can create a system by which we can actually real-time alert with participants. And so it looks like we did pretty good. We'll leave about 20 minutes for questions and answer. And with that, I'm going to stop sharing my screen. And because I didn't hear Brian interrupting me, but I couldn't see hands while I was sharing screen. So please feel free to take down my email or Twitter information and contact me afterwards if you have questions as well. Stop sharing. There we go.
Yeah, so if anybody has any questions, feel free to raise your hand or put them in the Q&A. We're happy to answer them.
And you can ask questions about anything. Doesn't have to be about this particular presentation. If you're doing work that's going to involve any kind of healthcare in the future, and you just have any kind of question related to that, then now's your chance.
Larry has one, yep.
Yeah. Hi, Larry.
Hi, Shelly. Can you hear me?
I can.
Okay. I had a question about electronic health records and what your thoughts are on, I guess the process towards standardization. As you know, I work in this space too, and it would really be nice if we had a place to store, all the long-term monitoring data, and then, draw it back and run algorithms on it and include some of their other health information. Is anything like that in the near future? Or are we still a long way away from, everybody kind of having all their health records online and being able to provide access to third party?
Mm-hmm. Yeah, that's a really good question. I would say my gut reaction to that is that we're still a ways off from that. And a lot of that's limited by the fact that there's basically two big players in the electronic health record space right now, Epic and Cerner. And they frankly don't like people to play in their sandbox. And I've heard that from representatives personally when they've come to the hospital to do updates, and I have the opportunity to talk with them, and also at conferences, technology conferences, where people are presenting innovation and whatnot. I've heard from innovators that they're just having a hard time breaking into that space. And I know for a lot of reasons. I mean, security being the number one reason, right? So Larry, actually, one of the things that I've been pondering and thinking that somebody needs to write a grant around, and I'm tossing this out there, that I don't necessarily own this idea. So anybody who can get it done, right? And that is that we need a national or international data repository with scrub data and the associated health information that's been annotated that can either be used to simulate future development of algorithms, or can be used to develop the products that we need. And I think that is an intermediary step that's probably needed. And once the technologies are good enough, I think that these electronic health record companies might show greater interest. But what I'm hearing on the front lines of healthcare right now from docs and nurses is like, I have so much to do right now. I don't even care about your data. Like, you're going to have to literally make this something that I can look at and understand in less than 60 seconds. And then I might use it. So they see the value in it when they have time, like in my classes with my F&P students, to think about it. They're like, yeah, this is really cool. We could use this. And you're absolutely right. We can't keep taking slices of data from a point in time and applying it to a prescription for the next year and then not see the patient, right? And know that things are varying. But the reality of healthcare on the front line is that, it's so time driven. So that's why I think it's a little ways off.
Okay, thank you.
Mm-hmm.
I actually have a follow-up question related to that I was wondering about. You mentioned having the ability to, look at ground truth and figuring that out with different clinicians looking at the data. And from my understanding, that's mostly looking at kind of the raw data, as you explained, from the sensor events. But I was wondering, are there certain like tools or ways of looking at the data that would be really useful to you as a clinician looking at it that, maybe an engineer could be looking at developing, or there's certain, at least like pathways of doing that that would be particularly useful that you don't really have, available right now?
Yeah, so you're talking about tools that we could use for annotating ground truth?
Yeah, and kind of being able to, look at it as a clinician to see,
Yeah.
okay, is this really a health event, or, because just looking at that raw data, I know you've gotten a lot better at looking at it than I've ever gotten, but being able to just look at the raw data, seems to me to be very tedious. Whereas if you have some way of visualizing it differently, I know that the dashboard in the Clinician-in-the-Loop was one option.
Yeah.
But I guess
Yeah.
there are tools that you could think of, that would be like, this would be really useful to have this way of looking at it, and they're not really available right now.
I really appreciate that question, because you're absolutely right. It's very, very tedious and time consuming to look at that data. And that is why people who are developing commercialized algorithms for like radiology, for example, we know that algorithms do a much more accurate and faster job at reading a chest x-ray than human radiologists can do. Like a radiologist has been doing it for 30 years, is not as accurate or as fast as a computer algorithm. But you know how they got there is they basically trained non-clinical people to look at those. Like they started out with docs and they're like, you cost too much. And the docs are like, this is too damn tedious, so they go hire other people to do it, right? And they were able to do it with non-clinicians, which is a whole other, study, really. When it comes to looking at this kind of health data, which what Diane and Maureen are working on in my mind is much more complex, because if you're going to focus on just one activity or just like chest x-rays, it's so narrow, that's not too hard to accomplish. But when you're talking about monitoring people in their homes with any diagnosis that could be out there and any behaviors that could be associated, that's a big lift, right? And a lot of tedious ground truthing. So I would love to see tools. We've developed a couple, just Katie and I will say mostly Katie because I'm more of a qualitative thinker and she's the quant person. But in Excel, like we use Excel extensively to like sort and to, we put in little rules to say, just show us if it's like been greater than 2 minutes or something like that. So if there was a tool that we could put in like rules, and it would produce like, okay, here's this set of raw data that's associated with these rules, I would think that would be really helpful. It would speed up our process. This started out with Shelly just looking at some data that Diane sent me, and I'm like, oh, this is really cool. I could see, but it was me scrolling through thousands of lines of data, right? And just applying, at that point, I think 22 years of nursing experience of working with people and watching them move when they don't feel well, right?
Yeah, that's actually really interesting to say, like a rule-based tool, because that's something that as computer scientists to go, oh, that's something that we could,
we do
fairly easily, right? But I think we don't really, that's why it's important, I think, to have these discussions, and why I appreciate working with people across the disciplines like this is, you have this discussion, all of a sudden you can realized, oh, there's this need out there, we could easily fill those needs,
Yeah.
So
and I think the conversation is important, because what you decide to put in a rule really has to be informed by the clinician who has a general idea from having cared for thousands of patients. Like, if you're going to choose 4 minutes versus 5 minutes, the problem is people can't really be put in boxes, and that's what we're trying to do. So that's part of the difficulty.
Agreed. Yeah.
I see Diane has a question.
Yeah. So Diane had one. I know she did have to leave, but her question basically was, what is the greatest technique that you think will help nurses of the future, particularly for remote care?
Yeah, I think that's a great question. The greatest tech need in the future regarding home care. I I mean, I think it's going to be a tool that helps us predict a change in health. So this idea of prediction is what will keep people out of the ER. And if we can keep people out of the ER that probably don't need to be there because of, you know, this is a chronic condition management versus the fact that you were in a car accident and, you know, your leg was severed. If we can keep people out of the ER with prediction models, that will save huge cost. It will save lives. It'll improve outcomes for patients. They'll be able to be at home longer, and it will open up the space in the ED for the people who really need it.
That's great. Yeah, I really like that idea. I really like that idea. If I could talk today.
Yeah.
Maureen also had a question, Jason, if you want to let her speak.
Hi, Shelly. Thanks for that great summary. I'll be excited to see the results of Katie's dissertation. I think this kind of piggybacks off of what you were just saying. And I was kind of curious about Katie's dissertation and her approach, which I think is really interesting. Does she, and I saw that she's targeting virility, does she see her approach as being able to capture and predict, say, both acute and chronic changes? Like, is it an approach that's going to be like a more proactive indicator for clinicians, or where, like, how is she conceptualizing what she might be able to capture?
Mm-hmm. I mean, I think at this point, she's conceptualizing it on, you know, the trajectory of decline for older adults that are experiencing Alzheimer's or dementia, but I think that she sees the application for it eventually beyond that. So I personally can see the application for more acute changes. And I can see that it could translate to, you know, persons with disability, any person across the aging continuum, actually. But with frailty, I mean, we're typically looking at people who are either the old, or as a translation, maybe people who are newly disabled and we are hoping are going to stabilize, but maybe are actually declining and becoming more frail. So the short answer to your question is I think she is not conceptualizing it from the acute standpoint, but rather more of a continuum and a trajectory. But I don't think that it has to stay at that point. I think that there is impetus for it being able to show a more acute at some point in the future.
Okay, I agree with that. I also thought it was interesting that you were talking of, or you know, that she's focusing on complexity and kind of going back to the other end of things in this new project that we're working on. We are actually going to be doing naturalistic observations of people in their own homes and trying to figure out the best way to code those observations. And so complexity is one of the things that we had settled on in terms of things like, you know, someone could fix a meal, but maybe they just put something in the microwave versus being able to, you know, do a couple of things simultaneously. And I agree that, you know, we're expecting that we will see those changes in complexity at, you know, like a more concrete level, but trying to capture them higher level is really interesting. And I think that could be very promising.
Yeah, I agree. Her looking at it in a more global aspect is part of what's really innovative and novel about what she's doing, because if you can do that, you can address this idea of privacy that is brought up in every qualitative study that I do around adoption. And you can also, I mean, you can address cost with that too. Like you can keep costs down, and yet you could still be able to identify when a reduction in complexity is happening. And actually, another novel thing about this is we think about complexity in healthcare and nursing as like, this is sort of the opposite, that somebody would be becoming less complex, because we often think that when people become more complex, they need more services, they need more assistance, and things become more complex in their life. But she's sort of reversed the thinking on that and is conceptualizing this in a way where when somebody's world narrows around them, that's a sign that they are becoming more frail.
Definitely. Thank you.
Yeah, great question.
We have time for a couple more questions if anybody else had any. Feel free to just raise your hand if you'd like, or put them in the Q&A still. I really appreciate, Shelly, your insights on these things, especially the connection between technology and clinicians has been, I know over the years, it's been very eye-opening for me to get to see that, because I kind of came from a pretty traditional engineering viewpoint of just, okay, the technology, look at the technology, how does the technology work? And as soon as you throw humans in the mix, it kind of everything goes sideways sometimes. And so being able to actually have perspectives from different clinicians and people that are actually involved kind of on the front lines with people using the technology is it's been very useful and helpful to me to kind of get that perspective and see the needs that are there too.
Yeah, thank you for that. And I mean, vice versa, Katie and I have been really blessed to be involved, at a technical level like this, because I can at least speak for myself. I mean, that original slide that I showed with, somebody thinking and going, and it led me back to research. I literally was one of those nurses at the bedside for 20 years going, if only a nurse had been part of this development team, we wouldn't be dealing with this. But anyway, so it's really nice to be a part at the ground level of what this can look like. And I think that, being able to develop a technology that can adapt to various situations is really important for me from a nursing perspective. You just can't envision every application that it will be used for. And so, and one of the things I hear from my research participants in the qualitative studies that I do also is that, they want options. They would like to have an assortment and be able to pick and choose. Like, I don't think I need that. Or, for example, a camera. Some people are not opposed to cameras in the main areas of the home. Other people are completely opposed to cameras. But the different sensors that you use and the different other technologies like microphones or cameras that you can use will tell you different things, and they can get at different aspects. And I guess if I had a plea of any kind for people who are going into the development of health technology is to always design with options for the end user in place. And I would say consider your number one end user, your patient, and your number two end user, the healthcare person who's assisting that patient. So, and if you can design with those things in mind, who is it? And who is the person assisting that person, right? And give them options. I know that increases cost, but also it's really expensive to develop stuff that's never going to be used. So
That's a very good point. Yeah. Thank you. Yeah, I definitely appreciate that perspective. I think it's a very good point, especially with considering not just the end user, but also the people helping them as well, the clinicians.
Yeah, because if it's healthcare technology, oftentimes it's being applied at the point where the person has somebody assisting them. And that could be, their partner or spouse or, live-in help, or it could be a nurse or a community health worker. As we're learning, we're going to see how that looks in the Smart Health System study that we're going to start in April, where we deploy a community health worker who's not trained in healthcare. And in several cases, these are going to be immigrants, people who have immigrated from other countries. And some of them are very educated, were lawyers in their home countries, but English is their fifth language and, their fifth place to live. But, and so they're working as community health aides or community health workers, but they're trusted because they speak in the dialects that are needed. And clearly they're intelligent people, right? And we're training them in, what we are wanting from this technology and their assistance, with the end user, right? So.
Yeah, that's awesome. All right, well, I guess we've reached 10 o'clock. So Shelly, thank you for your time today and for sharing these things. And thank you everybody else for attending today. And hopefully this leads to some good discussion and interaction in the future. So.
Thank you again.
you.
Have a good day, everyone.
Yep. Bye.